Thank you for inviting me to participate at the TASL meeting. I'm very delighted that AASLD and TASL are collaborating again in this symposium. It is unfortunate that we're not able to see you in person, but we still hope that we can continue to collaborate and see each other again next year. And I look forward to enjoying this meeting with you all. These are my disclosures, and this is an outline of my talk. I'll talk about trends and incidence of HBV-related HCC in the US after the introduction of NEWS, the impact of NEWS on the incidence of HCC in patients with chronic hepatitis B, and the unique challenges studying HBV-related HCC in the US. As you can see from this slide, the incidence of liver and intrahepatic bile duct cancers in the US has continued to increase in the last 2 decades. There is, however, hope that in the last couple of years, we might finally be seeing a decrease. The slide previously showed all liver and intrahepatic bile duct cancer. This slide, however, shows age-standardized mortality rates for HCC by etiology. And you can see that while mortality has been increasing for other etiologies or flat for hepatitis C, it's been slowly declining for hepatitis B since 2010, most likely related to the impact of NUC therapy. The impact of NUC therapy is also seen in the number of patients being listed for liver transplantation for hepatitis B. After the introduction of lamivudine and then adavovir, you can see, based on the height of the columns, a decrease in number of patients listed for liver transplantation for hepatitis B. The dotted line, highlighted by the HCC bar, indicates the number of patients listed specifically for HBV-related HCC. That has continued to increase until most recently in 2013, where there is beginning to be a decline. However, some of that increase since 2002 is related to the introduction of MEL, which tends to favor listing of patients with HCC. A fairly substantial proportion of patients listed for liver transplant in the United States have HCC, and majority of them have been related to hepatitis C, although in recent years there's also been a progressive increase in the purple line, which are the NASH-related HCC. By contrast, the proportion of HCC on the liver transplant waiting list due to hepatitis B has been slowly declining since 2003. And that's really largely related to the introduction of new therapy. We all know that in order to eliminate hepatitis B, vaccine is the most effective. However, for prevention of patients with chronic hepatitis B, it is important that antiviral therapy be implemented because it not only can reduce the disease burden, progression to cirrhosis and liver cancer, but also reduce the spread among the community. I'll now talk about the impact of NUCs on incidence of HCC in patients with chronic hepatitis B. And I'll share data from the European studies and then the US studies, because there are not too many studies in the United States. For this first slide, is actually from Henry Chen and Grace Wong's group, where they show the benefit of antiviral therapy in reducing HCC, decompensation, and liver-related mortality, more so in patients who also managed to clear surface antigen, compared to those patients with suppressed DNA, but still remain HBs antigen positive. There was a further reduction in HCC incidence. The impact of NUC on HCC is not immediate. This is not surprising because antiviral therapy does not complete Antiviral therapy takes time in order to reduce that risk. And here is some data from George Papatheodorou group combining data from multiple European centers, totaling roughly 2,000 patients. And you can see that there's a linear increase in the incidence of HCC in the first 5 years, but in the cirrhosis group, where the incidence occurs at a higher rate, after year 5, you begin to see a decrease in the slope. After year 5, the major risk factors are older age, lower platelet at baseline in year 5, as well as higher liver stiffness score at year 5. More recently, they have extended the data and shown that in patients with chronic hepatitis B receiving NUC therapy, the survival is comparable to general population when matched for country, age, sex, and calendar year. This is also true for patients with cirrhosis at entry. However, this is not true for patients who develop HCC, where the risk of mortality is 3-fold higher. As more and more patients stay on antiviral therapy for longer, many of us are interested in what is the risk of HCC during subsequent years, and how do we actually know which patients are going to develop HCC in later years. And this is again data from George Papatheodorou group, where they now have 1,400 patients with greater than 5-year follow-up on entecavir or tenofovir. And during the period year 5 to 12, there were only 2.3% of patients who developed HCC. And the risk factors for late HCC were older age, baseline cirrhosis, and high liver stiffness score at year 5. And among patients with baseline cirrhosis, those with lower liver stiffness score at year 5 also had a reduced risk of HCC. They therefore developed the SAGE-B score, which comprised the age as well as the liver stiffness score at year 5, and showed an AURC of greater than 0.8 in predicting late HCC. I now will share with you several studies performed in the US. The first is the Enumerate study, in which I also participated. This is a retrospective observational study of chronic hepatitis B patients who received entecavir for greater than 12 months between 2005 and 2013. 841 patients were included. 65% of them were men, 84% of them were Asians, and median age was 47 years. A third of them were antigen positive, and 9.4% of them had cirrhosis. The median follow-up was 4 years, with 17 patients developing HCC. The risk factors, as you would expect, were older age and presence of cirrhosis. Because there was no control group, we used a RICH-B model developed in Taiwan to predict the HCC risk and compare the expected, the dotted line, with the observed, the circles. You can see that for the overall group, there was a reduction in HCC risk by year 8. And in the no cirrhosis group, which is the larger group, by year 4, a difference was already observed with a 60% reduction. Because of the small number of patients with cirrhosis, we were not able to show a difference. Another study in the US was initiated by the CDC, and this combined 4 US health centers, including 2,671 patients with hepatitis B diagnosed between 1992 to 2001. The study relied on retrospective review of electronic medical records. Half of them were men, half of them were older than 50, and half of them were Asian. A third of them received antiviral therapy. HCC developed in 67 or 3% of patients during a median follow-up of 5.2 years. 20 of those who received antiviral therapy developed HCC, and 47 in the untreated groups, but these two groups were obviously not comparable. So they performed multivariate analysis, and not surprisingly, independent predictors of HCC were older age, men, elevated ALT. But those who received antiviral therapy had a 50% reduction in risk of HCC. There were, however, other confounders that cannot be adjusted for due to missing data. A lot of the studies on hepatitis B and HCC, as well as some new therapy, were conducted by Minnie Wynn from Stanford. And in most of the studies, she combined data from US patients with from studies in Asia. And this is one such study where she used data from 6 US centers, both treated and untreated patients, and used the review cohort in Taiwan, largely untreated patients, as the comparison group. So there were 6,140 untreated and 774 tenofovir treated patients. Because of the mismatch, she also performed propensity score matching. The 8-year cumulative incidence of HCC in untreated and the TDF treated patients were 20% versus 4.7%. On multivariate analysis, age, cirrhosis, and treatment were independently associated with HCC, and cirrhosis was, as expected, the most important risk factor. Here she showed in a propensity score match comparison between the untreated and tenofovir treated patients, the treatment resulted in a reduction in the risk of HCC in the overall cohort, the cirrhosis subgroup, as well as the no cirrhosis subgroup. In recent years, there have been a lot of debate as to whether there's a difference in efficacy of tenofovir versus entecavir in preventing HCC. Much of the studies have come from Asian countries, but even within Asian countries, the data is somewhat controversial, with even within Korea itself, some studies showing a difference and others not. In this particular study, Mindy again, together with her collaborators, included patients from 19 centers in the US and Asia. Patients received a minimum of 1 year of treatment. Majority of them received entecavir. And this is largely because tenofovir was introduced into Asia at a later stage. If you only look at the US patients, there were more comparable number receiving entecavir and tenofovir. They performed competing risk analysis, and what you can see is that when you look at the overall cohort, there was indeed an indication that tenofovir was associated with lower risk of HCC, which is also true in the Asia subgroup. But this was no longer observed when we look at the US subgroup. There were, however, differences between the entecavir and the tenofovir group in that the entecavir treated patients were older, had higher HBV DNA, they were more likely to have cirrhosis, and also more likely to have decompensation. And when propensity matching cohorts were compared, there was no difference in HCC between the two treatments. As I've indicated earlier, recently there have been a lot of interest in developing prediction of late HCC in patients who've been on oral antiviral therapy for many years. This is again Mindy collaborating with Dr. Yang in Taiwan, looking at 8,000 patients from 6 US centers as well as 19 Asia Pacific centers. Majority of them were Chinese, mean age 48, and 21% of them had cirrhosis. They divided the patients into derivation cohort and validation cohort, with 7% in the derivation cohort developing HCC and 7.5% in the validation cohort developing HCC during follow-up. The risk factors included gender, age, alcohol use, diabetes, baseline cirrhosis, and baseline platelet and AFP. They used this to combine as a real B score with area under the operating and receiver operating curve of 0.8 in the derivation cohort, as well as in the validation cohort for prediction from 3 years outwards to 10 years, and show that the real B score performed better than PHB, Rich B, GET HCC, and CU HCC. However, they have not compared with other models that specifically look at HCC on treatment, including on treatment variables. And I'm sure that they work on that right now. Now, I finally would move on to talk about unique challenges in studying HBV-related HCC in the United States. As we all know, the United States is a melting pot with people immigrating from different parts of the world. And a country of birth has a major impact on HCC, particularly HBV-related HCC. This is located in the CS database, which is the Surveillance, Epidemiology, and End Results Program in the US, which keeps track of HCC incidence as well as mortality. Here they included close to 60,000 incident HCC cases diagnosed between 2000 and 2012. Although the median age of diagnosis was 62, there were a substantial number of patients that presented very early HCC before the age of 40. And this is particularly true for foreign-born, particularly if they were foreign-born Blacks, in particular those who were born in West Africa. Among the Blacks, only 1.8% presented with HCC before the age of 40, whereas it was 28% in those born in West Africa, 5.7% of those born in East Africa. Among Asians, there was not much difference regardless of the country of birth. Now, even though we don't have specific etiology here, we know that this is predominantly related to, among the foreign-born, this is predominantly related to hepatitis B. We've also shown in the NIH-funded hepatitis B research network, which included 21 North American centers, the heterogeneity of hepatitis B that we see in the United States. Majority of the patients were actually born in Asia, and not surprisingly, have predominant Asian genotypes, B and C. There's also a substantial number of patients born in Africa with predominantly African genotypes A and E, whereas in those patients who were born in US and Canada, it was a very mixed genotype with A, B, C, and D all represented. Now, these have some implications because, as I indicated in the CS database, West African-born patients were more likely to present with HCC at a very young age. In the HBRN, among the 200 plus Blacks, 57 of them were born in the US. Majority of them were born in East Africa, but we also had a fairly substantial number born in West Africa. And we can see that there's a difference in the prevalence of the antigen, as well as in the prevalence with normal ALT and low DNA. But most strikingly is when we look at the genotype. In the US born, they were predominantly genotype A, and in East Africa, it was mostly genotype A and B. But the subgenotype in those that were born in East Africa were different from those that were born in the US. And in West Africa, the most common genotype was E. So these differences in genotype could play a role in the disease progression, in particular with HCC. Whether they respond as well to NUC therapy is unclear. Well, we've shown the benefit of NUC therapy, it would only be helpful to patients who've been diagnosed and linked to care and placed on treatment when indicated. Unfortunately, the cascade of care is dismal in the US, even within patients who have private insurance. This is looking at 7,000 patients with private insurance between 2013 to 2017. Only 41% of them had further evaluations after positive HBsAg testing, which include checking for ALT, e-antigen status, or HBV DNA. And only 28% of them had those evaluations within 1 year of diagnosis. Within those who have been diagnosed, 8% of them will be considered treatment eligible based on guidelines. And a total of only 1.6% received treatment. That's less than 20% of those that were eligible for therapy. So this clearly needs to be improved in order that NUC therapy can benefit patients. And when patients are diagnosed and linked to care, they can benefit. And this is shown very clearly in the HBRN. HBRN, where 1,400 patients were followed, they had a median age of 41 years. Half of them were women. Majority of them were Black. A quarter of them were antigen positive at baseline, but very few of them had cirrhosis. This is because for entry into HBRN, patients should not be receiving antiviral therapy at entry. However, after they enter the study, if there was clear indications for treatment, they could be started on treatment, and indeed 274 did so. During the course of follow-up, which is a median of about 6 years, we had very few outcomes. Only 8 of the participants had clinical outcomes that included HCC, decompensation, death, as well as instant cirrhosis. Not surprisingly, the majority of these outcomes occurred in the group with cirrhosis, whereas in the group that did not have cirrhosis, the entry, even when we look at outcomes that included instant cirrhosis, only 2% of them had outcomes. If we specifically look at HCC, there were only 5 of them, 3 Asians, 2 white. Interestingly, none of the blacks. Most of them were men, older. 2 of them, HCC developed even though they've been started on NUC with viral suppression. 2 of them had persistently undetectable HBV DNA, and only 1 of them had elevated HBV DNA, who could have potentially been started on treatment. Thus, in summary, the instance of mortality from HBV-related HCC in the US is decreasing after the introduction of NUCs. HBV infection is under-recognized and underdiagnosed in the US. Improvement in diagnosis and linkage to care and initiation of antiviral therapy when indicated can prevent adverse clinical outcomes, including HCC in patients with chronic hepatitis B infection. Thank you for your attention.